Okay, good morning, student. Actually, today HOD sir will take your class, but due to some problem, he will be a little bit late. So still, I'll tell something briefly about the complication. So mainly complication, how it occurs, and what are the complication. You have to know. Mainly, we divide the complication into intracranial and extracranial complication. Okay. So among the extracranial means outside the brain. No? So extracranial complication we divide it into two categories. Mainly the intratemporal and extratemporal. Intratemporal is like it's inside the middle ear cavity or inner ear. It involves the ear and mastoid bone, means the temporal bone. And the extratemporal is like outside the brain as well as outside the temporal bone. Okay, it will be in the skin. All the abscesses outside the temporal bone are the extratemporal complication. Uh, so mainly how it occurs, no? So the complication occur when infection spread beyond the mucoperiosteal lining of the middle ear cleft. So as you know, the otitis media. What is otitis media? No? Otitis media is the inflammation of the middle ear cleft, in simple term. So from that mucosal lining of the middle ear cleft, if the infection spread to other structures like in cholesteatoma, as you know already, cholesteatoma involves the bone because of the enzymatic activity. So when it involves the bone, then into the neighboring structure like when the infection spread to facial nerve, then inner ear like labyrinth, cochlea and all, then through some venous channel it will go to sigmoid sinus, lateral sinus, and it will cause their sigmoid sinus thrombosis. Then through hematogenous spread or direct spread, it will lead to meningitis. Okay, so it will tell it as complication when it spread to the all those structure like the bone. When it involve the bone, it will lead to petrositis, labyrinthitis, mastoiditis. All are the complication. All these are the complication where it involves the bone. Then it may involve the facial nerve, inner ear, sinuses, and meninges. Okay. So almost 1/3 of the patient with CSOM will have the complication, and children are mostly affected. Means in children complications are more because of their less immunity and all. So what are the factors affecting the complication? So pathogen factor are high virulence of bacteria and antimicrobial resistance. So whenever there is any infection in the middle ear cavity, so so as you already know, in acute ASOM cases, there will be infection of Haemophilus influenza, Streptococcus pneumoniae, and Klebsiella and all. And in chronic CSOM, there will be infection with Pseudomonas, mainly Haemophilus influenza, Catarrhalis and all. So whenever there is high virulence of the bacteria, it will lead to the complication. Then some bacteria are antimicrobial resistant. So these are also a cause for complication. You are giving antibiotic, but it's not responding, and ultimately it will lead to a complication. Okay. Then patient's factors are also responsible, like young children. As I already told, small kids or small children is more affected than the younger means adult. Then poor immune status, concurrent chronic diseases. If patient is having diabetes mellitus, hypertension, other chronic diseases, renal diseases, they are more prone for complication. Okay. Then poor socioeconomic status and lack of health awareness, because patient won't come to you with a few days of discharge, and they will keep this discharge for long, 2 years, 7 years, 10 years. After that, they will come with all complication. You can hear, na?
Yes, sir.
Okay. I will go fast because it's a long topic. I have to cover. Actually, HODs are supposed to take the class. I am also not prepared. So I'll just tell you something. Okay. If you don't understand, you just ask me. So etiology among the bacteria or bacterial etiology, in case of ASOM, I already told, ASOM is caused by Streptococcus pyogenes, mainly Haemophilus influenza, Moraxella catarrhalis, and Staphylococcus aureus in few cases. And the most common cause of CSOM is Pseudomonas aeruginosa, then Proteus, Klebsiella, E. coli, etc. So how it spread actually, the how the complication occur in bone or blood means meninges and venous channels. Venous channels. So it spread during acute infection. When there is acute CSOM, it will lead to hyperemia. Means during inflammation there will be more blood flow, more due to chemotaxis, more inflammatory cells will come, and it will lead to decalcification of the mastoid means temporal bone. So the hyperemic decalcification is one of the cause for bone destruction, and in during chronic infection due to cholesteatoma resorption or osteitis. Osteitis means inflammation of the bone matrix. So it will lead to destruction of bone and bony septum. As you know, mastoid cortex, it has septum trabecula inside it. So due to osteitis, all the trabecula will get broke, and it will lead to accumulation of the infection. So and these are the direct bone erosion route of spread. No? The direct bone erosion in acute case it's due to hyperemic decalcification, and in chronic case is due to the resorption by cholesteatoma. And thrombophlebitis, there are some venous drainages inside the medullary cavity. Through that infection can spread to sigmoid sinus, from sigmoid sinus, cavernous sinus. So through the venous channel, the infection can spread, and it will lead to thrombophlebitis. Okay. Then from normal anatomical pathway, so there are some dehiscence in the medullary cavity. As you know, oval window, round window is not a bony hard structure. So in the medial wall of the medullary cavity, there is the oval window and the round window, which is just a like a membrane. It's a niche, not a bony structure. So through that window, infection from the medullary cavity can spread to the inner ear and can spread to the other structures. Then cochlear and vestibular aqueduct. From the aqueduct, the infection can spread to the inner ear. Then dehiscence of tegmen tympani. So as you know, the roof of the medullary cavity is formed by the tegmen tympani. So any dehiscence in the tegmen tympani, there will be spread of infection. Okay, these are the normal anatomical pathway. Non-anatomical bony defects are like whenever there is fracture of temporal bone due to RTA or any surgery, any accident. These are like not inborn. It's acquired cause of means acquired bony defect, and it may spread to the brain through the periarteriolar space of Farsu Robbins. So Farsu Robbins space of there is a space around the artery or vein. So through that space, infection can spread to the brain. So now I will. You should know this slide mainly. What are the means how we classify the complication of CSOM. So we mainly classify it as intratemporal. Means one is intracranial, one is extracranial. Okay. So extracranial means it's outside the brain. So we divide this extracranial complication into intratemporal and extratemporal. So intratemporal complication means it's within the temporal bone. So these are mastoiditis, petrositis, labyrinthitis, labyrinthine fistula, and facial nerve paralysis. Okay, and extratemporal means outside the temporal bone. So it's mainly all the abscesses like subperiosteal abscess, Citylis abscess, basal abscess, lux abscess, zygomatic abscess, and occipital abscess. Okay. And intracranial, among the intracranial complication, these are meningitis, extradural abscess, subdural abscess, brain abscess, then most common lateral sinus thrombosis or sigmoid sinus thrombosis, and hydrocephalus. Okay. And systemic, this infection may lead to septicemia and autogenic tinnitus if it's caused by Clostridium tetani. Okay. Hello.
Yes,
Hello.
sir.
Yeah, I'll tell a little bit about all the complication, and you go through the book. Okay, till HOD come, I'll tell small, little for every all topics. Okay.
Yes, sir.
So among the intratemporal, if in entrance also they might ask question, which is the most common intratemporal or intracranial. These are two different issues. Okay, intracranial, if they ask, it's the meningitis. Meningitis is the most common complication. And if they ask intratemporal or extracranial, then it will be the labyrinthitis. Okay, because labyrinth is where it's the inner ear. Inner ear is the most it's close association with the middle ear. No, so their infection is the most common. Okay. Now mastoiditis. So mastoiditis, it usually like due to spread of infection directly to from the middle ear cleft, because middle ear cleft consists of middle ear cavity, mastoid cortex, everything. So the lining of the mucoperiosteal lining is similar. So any infection from the middle ear, it will easily spread to the mastoid cortex or mastoid antrum. And usually mastoiditis, if you see, we can divide the mastoiditis into stages. Like first periosteitis. Periosteitis means the outside the bony layer. No, so that will be inflamed. Periosteitis mainly occur due to emissary vein the infection will spread through the emissary vein. Mastoid bone have some emissary vein. So through that emissary vein from the middle ear cavity, infection will spread to the periosteum. It will lead to periosteitis. Then the stage will come, it's called osteitis. Osteitis means the actual bone of the mastoid cortex will involve, and we call osteitis as coalescent mastoiditis also, because during osteitis stage, all the trabecula of the cortex of mastoid will get broken down. So there will be coalescence of the mastoid antrum, and there will accumulation of pus. So we call it as coalescent mastoiditis. Okay. Though here I already wrote in this slide, coalescent, this is destruction of wall of trabecular air cells, and they are joining together to form a single irregular mastoid cavity. Okay. So osteitis, stage of the mastoiditis, we also call as coalescent mastoiditis. And there are two stages more, subacute mastoiditis or latent mastoiditis. Subacute mastoiditis is where you are giving inappropriate antibiotic treatment. So within 10 days, you give for 10 days you give antibiotic, but it's not appropriate, not according to bacterial sensitivity. So it won't resolve. Then we call it as subacute mastoiditis. And there are some latent mastoiditis also, where no sign, there won't be any sign of inflammation of the middle ear. That is, there won't be any otorrhea or pain or fever, but the mastoid tenderness will be there. Like infection will typically will be present in the mastoid cavity. We'll call as latent mastoiditis. So here mainly important is coalescent mastoiditis. This is the most dangerous, where all the bony trabecula will broken down, and it will lead to coalescence. Okay, mostly occur in children and well pneumatized mastoid. If suppose there is a sclerotic mastoid, there is no air space, no trabecula, then the infection cannot cause any trabecular destruction, because there is no trabecula only. So the spread of the infection will be restricted. But in case of well pneumatized mastoid, there will be lots of air cell, there will be lots of small thin trabecula, which will get broken down and will lead to more extensive disease. Okay. Then this is this picture of coalescent mastoiditis. Here in the green color you can see usually there will be lots of septum in the mastoid cortex, but here there is no septum. It's become a single cavity. That green color actually represent accumulation of pus. So, and as you can see, it break the mastoid wall in the lateral surface. It breaks the mastoid wall, and the pus come outside actually, which will lead to, later on it will lead to abscesses. That is the extratemporal complication. Okay. So how the mastoiditis occur? First stage is editus block. No? Whenever there will be inflammation of the mucoperiosteal layer of middle ear cleft, it will due to inflammation, the mastoid editus will get blocked, and due to which the mastoid, there is a failure of drainage. So whatever accumulation, whatever discharge is there in the mastoid cavity, it won't be able to come out through the middle ear. So there will be failure of drainage. Then status of secretion will remain in the mastoid ear cavity. Then there will be hyperemic decalcification. As I already told, due to hyperemia inflammation, there will be decalcification of the bone, then resorption of the bony wall of air cell, and ultimately it will lead to coalescence of the small air cell septum. Okay, and it will form a single mastoid cavity. Then symptom mastoiditis symptom, all the CSOM symptom will be there, like ARA will be there. Okay, more than 2 weeks increase intensity and recurrence of pain within 3 weeks. Suppose one patient came with previously came with ARA, and after 7 days there was no pain, but within 3 weeks again the pain reoccur. It means there is some hidden infection in the temporal bone. That is, it's a mastoiditis. Okay, there is infection in the mastoidal cavity which again reoccur as ARF. Then fever will be there due to infection. Postural pain. So postural pain, this symptom means what? Patient will tell all those things. Okay, ARF, then fever, pain behind the ear, decrease in hearing due to rupture of tympanic membrane or due to cholesteatoma. Then air discharge will be there. Okay, but in marked mastoiditis or latent mastoiditis, I already told, absence of classical symptom due to inadequate antibiotic use. So in mass mastoiditis, there won't be any classical symptom like CSOM or ASOM symptom won't be there. Okay, in mass mastoiditis. Then sign is like pinna. No, when there is mastoiditis, involvement of the mastoid cortex, inflammation of the mastoid cortex, it will push the pinna forward and downward. Okay. Then there is a postauricular groove. That postauricular groove will obliterate in case of mastoiditis. I will show one picture. As you can see in this small kid, the second slide you see there is in swelling of behind the postauricular means pinna. So it will lead to obliteration of the groove, postauricular groove, and as you can see the pinna is pushed little bit downward and forward. Okay, and when you examine, when you palpate the area, it's obviously it will be tender. And iron means iron out mastoid means what? If you touch a normal mastoid bone in a normal person, you will feel some irregularity. But in case of mastoiditis, those irregularity will won't be there due to inflammation. So it's called as iron out mastoiditis. It will be smooth. Okay, obliteration of retroauricular groove. All these are the means sign. And sagging of posterior superior bony wall of ESA. This is a otoscopic finding. When you see the ESA, there the ESA has 4 wall, na? So the posterior superior bony wall will be there will be sagging, like there will be narrowing of the ESA. Okay, and reservoir sign, when there is mastoiditis, there will be infection in the mastoidal cavity. So obviously there is accumulation of pus, so that pus will come out through the perforation. If you clean the ESC, then again you will see some discharges coming out from the medullary cavity. That is called reservoir sign. You will see in mastoiditis. Okay. Hello. Hello.
Yes, sir.
Okay. You can understand something?
Yes, sir.
Okay. Now, after sign symptom, what are the investigation? When a patient come with mastoiditis in your OPD, first in any surgical cases, in ENT or any surgical cases, we do all the routine investigation like TLC, ESR. These are if there is any infection or inflammation, we always do TLC, total leukocytic count, to it will be raised. Then ESR will be raised. These are inflammatory marker, na? ESR, ferritin and all. So it will be raised. Then we advise one X-ray mastoid. So if we do X-ray mastoid, there will be normally the mastoid air cell is like black. It will be black in color, and you can see easily the mastoid air cell. No? But in case of mastoiditis, in case of accumulation, there will be clouding, means haziness of the mastoid air cell. Then those partition or trabecula of the air cell will be indistinct, like broken. Or in coalescent mastoiditis, you won't see any trabecular only, and irregular wall cavity. Then X-ray mastoid, more HRCT temporal bone is the diagnostic tool. No? So we have to do one HRCT temporal bone so that we can see the mastoid antrum also, medullary cavity, ossicle, everything we can see in HRCT temporal bone. So that's why HRCT temporal bone is the investigation of choice for mastoiditis. And we will send one pus culture so that we can start exact antibiotic therapy, okay, according to the sensitivity. Then treatment will be IV antibiotic and mastoidectomy. I won't go details about the mastoidectomy. What are the types of mastoidectomy or what are the procedure? I won't tell. Just you know that in case of mastoiditis, we will do mastoidectomy, cortical, simple, canal wall up, canal wall down, depending on the severity and the disease condition. Like in case of cholesteatoma, extensive cholesteatoma, we may go for modified radical mastoidectomy or canal wall up or canal wall down, both maybe. Or if the in case of acute ASOM or acute mastoiditis, we'll do only simple mastoidectomy. That is the we'll drill out the mastoid antrum and we'll remove the bone. Means infection, pus or something, anything. We won't destroy any other air cell. We won't go to medullary cavity. We'll just remove the antrum. That is called simple mastoidectomy. But if we remove the other cortical cells, then we call it cortical mastoidectomy. There are lots of types are there. So that will be covered in mastoidectomy part. So you read that part. But here, as a complication, you no need to write everything. Just write IV antibiotic. We have to start and mastoidectomy. Then now coming to the abscesses, you don't confuse this. Mastoiditis is intratemporal, but abscess is extratemporal complication. Okay, so abscess we usually see 6 types of abscess during as a complication of CSOM. They are the subperiosteal mastoid abscess, basal abscess, citylis abscess, lax abscess, zygomatic abscess, and occipital abscess. So the clinical features and everything will be the same: fever, pain, otorrhea, everything will be there, and there will be a swelling. So according to the position of the swelling, we named it as different type. So as you can see, one is subperiosteal mastoid abscess. Na? So the abscess will be there in the subperiosteal region. It will break the cortex bone. Then below the periosteum, the accumulation will be there. So it will be just behind the ear. That is subperiosteal mastoid abscess. Basal abscess is when the medial wall of the mastoid cortex will get broken down due to inflammation. The pus will trickle down through the sternocleidomastoid muscle, along the sternocleidomastoid muscle. Then we call it as basal abscess. Then citylis abscess, the abscess will drain along the digastric, posterior belly of digastric. Then lax abscess is along the EAC. Okay, the infection from the medullary, it will come, the inflammation will come along the EAC, and there will be around the tragus, there will be swelling. Then lax zygomatic abscess, in the zygomatic root area, there will be the abscess. And occipital abscess, it will go behind in the occipital region, there will be abscess. Okay, according to position, we named it as different type, but main cause, pathogenesis, means root, everything is same. Clinical sign symptom is same. Just depending on the position, we named it as different group. Then postoral subperiosteal mastoid abscess is the most common abscess. It usually occur in the McEwen's triangle below the periosteum. Okay, and this is due to the direct cortical erosion. Okay, and infection will or the pus will come through the vessels in the mastoidic cribrosa. That is anatomical part, I won't tell. But just the abscess will be there in the McEwen's triangle region. Okay, behind the ear. That is postoral subperiosteal abscess. Then occur in 50% of case. That's why it's most common type. Basal abscess, I already told, along the sternocleidomastoid. Citylis abscess along the posterior belly of digastric. Temporozygomatic abscess, that is root of the zygomatic bone. Occipital abscess, it's along the mastoid emissary vein. That's why it's mastoid emissary vein. That foramen will be in the behind. That's why the spread will till the occipital region and deep neck space abscess. So there may be sometime there may be parapharyngeal retropharyngeal abscess also due to spread through the peritubal spread. Means in the medullary cavity, you know, there is a eustachian tube opening in the anterior wall of the medullary cavity. So through that eustachian tube opening, there is a small, there will be some space along the tube, so infection can spread through the peritubal space, and it will come to pharynx, means retropharyngeal or parapharyngeal spaces. This is postoral fistula. This is also a complication. After the abscess, there will be fistula formation. So it you will see it together, abscess with fistula. Okay, and mastoid abscess you can see in that picture, second picture. There is this projector. I don't know how to okay, there is collection. As you can see, that whitish part is the bone, no? So behind. So there is accumulation of some pus, haziness below the skin and beyond the bony cortex. So that is the accumulation actually. Then treatment, whenever a patient will come with mastoid abscess, you just admit the patient, start broad spectrum antibiotic, anti-inflammatory, means all symptomatic management you have to give, like painkiller, for fever you have to give antipyretic, fluid means fluid, and you have to start one broad spectrum antibiotic till the CS report come. Then surgical treatment, when there is no response to medical treatment within 2 days, then there is response, but still the abscess is there, it's not resolving. You already given the treatment for 2 weeks, then you have to do surgery. Okay, so what are the surgery? Incision and drainage of the abscess and cortical mastoidectomy. So first of all, you have to drain the abscess. Wherever there is abscess, you have to drain the abscess, and also you have to do cortical mastoidectomy to remove the main cause of that abscess. No? Wherever there is collection in the mastoidentrum, you have to remove that part. Along with that, you have to do the abscess drain. Okay. Then someone may ask you, like a differential diagnosis of abscess, no? So, or acute mastoiditis is the pharynculosis. So pharynculosis behind the pinna also present to you, like same as mastoiditis. No? There will be preauricular, means postauricular swelling. Then there will be pain, tenderness, but there won't be any discharge postauricular, like sagging of the posterior wall of ESC. There won't be any coalescence of the mastoid antrum. You have to differentiate it along. Means whenever you do the investigation, you will come to know that it's not a mastoiditis, it's a pharynculosis, but it is the differential diagnosis. Okay, one of the differential diagnosis. Then petrositis. Then now when the infection spread along the temporal bone till the petrous affects, so means medullary infection can spread to the petrous apex. So acute petrositis, the main clinical symptom is, we call this as Gradenigo syndrome. Okay, this is one entrance question. This is important. Acute petrositis, involvement of the petrous apex air cell. Okay, so in only 20% of cases petrous apex air cells are there. Usually petrous apex is not pneumatized, but in 20% cases it is pneumatized. So infection can spread to that petrous apex air cell. So why it's difficult, means why it is dangerous? Because it's petrous apex. If you see the anatomy book or you know the skull base anatomy, then you will come to know that petrous apex is in the inside the cranium, in the brain. So it's very difficult to drain from that area. Okay, and near the petrous apex there are lots of nerve and neurovascular structure, like trigeminal nerve, abducens nerve. Then in the petrous apex, in means internal aquaristic matters, there will be facial nerves and 8th nerve. So all the neurovascular structure will be there. So any surgery is difficult in that place. So clinical feature, you have to mainly know what is the clinical feature. That is the Gradenigo syndrome. You don't have to memorize the Gradenigo syndrome, because Gradenigo syndrome you can easily memorize. You will retain the, you have to means understand how it is happening. So first of all, there is a CSOM, so there will be some discharge from the ear. That is the first sign or means symptom. That is otorrhea. Okay, then these are the Gradenigo syndrome. First, I'll tell the persistent air discharge, then retroorbital pain, then there is diplopia due to abduction nerve. So, if you can see in the first slide, the Petras effects, that is yellow, blue color, some mark is there. That part is the Petras effects part. So there will be some nerve structure there. Those are the abduction nerves and trigeminal nerve. So any infection will involve them also. So it will lead to all these symptoms. So if infection involves the abducens nerve, what it supplies? Sixth nerve. Hello. 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 Hello.
Hello. Yes, sir.
Yeah, you are you listening?
Yes, sir.
Abducens nerve, what it supply?
Lateral rectus.
Okay, so if there is involvement or paralysis of the abduction nerve, so what will be there? Diplopia, no? Because SO4 LR6. So if the muscle of the eye, extraocular muscle get involved, then obviously there will be diplopia. Okay, one eye will be seeing other thing, and due to paralysis, other eye will be in another gaze. So there will be diplopia. Okay, so you just have to know little bit anatomy idea. What are the structures around the Petras effects? Then you will easily make out what is the Gradenigo syndrome. So there will be abduction nerve, so there will be diplopia. So nearby that area there is trigeminal nerve. So if there is involvement of the trigeminal nerve, there will be retroorbital pain or deep-seated pain. Okay, and there will be discharge persistently because there is a CSOM. Okay, so all these three symptoms together we call it as Gradenigo syndrome. Okay. Then treatment, usually treatment is like for all complication or CSOM, it's almost same. We have to do everything. Means only the surgical approach is different for different complication, but otherwise you have to start antibiotic because all this complication is due to infection. So you have to start antibiotic. You have to start anti-inflammatory agent. Okay. Regarding the surgery of the petrositis, look to Petras effects is not so easily accessible thing, no? It's inside the brain. So if you do any surgery in the Petras effects, you have to go through the you have to do mastoidectomy. Then you have to go through translabyrinthine approach. Means what? You have to destroy all the labyrinth and you have to go inside till the Petras apex. So if so you have to there are lots of route to go to the Petras effects, but it depends on the hearing. So if a patient come to you without any residual hearing, both the air air is damaged already, there is no residual function like labyrinthitis or something, then you can easily destroy the labyrinth. There is no issue with that. So you can approach through translabyrinthine route or transcochlear route. But if there is residual hearing, then you can just destroy the labyrinth. Then you have to go through retro labyrinthine route or infracochlear route. Okay. Then if there is residual hearing, you also have to preserve the hearing and you have to go below that labyrinth and you have to reach the Petras apex. And this surgical main aim is to what is the aim of the surgery? We have to remove the abscess or collection. Okay, like mastoidectomy, we are removing the collection from the mastoid antrum. Like same in petrositis, there will be collection in the Petras apex, so we have to remove the abscess, nothing else. Then labyrinthitis. So I already told in the intratemporal complication, labyrinthitis is the most common. Okay, there are two type of labyrinthitis. It may be serous labyrinthitis. Serous labyrinthitis means what? It's just an accumulation. There is not such infection. So serous labyrinthitis, it's not with total loss of function. Labyrinthitis means inflammation of the labyrinth. So labyrinth, it contains the semicircular canal, vestibule, cochlea, everything. So if there is labyrinthitis, inflammation of that labyrinth, so there will be loss of function of the semicircular canal or cochlea. So in serous labyrinthitis, there will be hampering of the function, but it's not like total loss of function. But in case of purulent or suppurative labyrinthitis, there is a permanent loss of function. Okay, there will be permanent loss of function. The cause is same, osteitis of the labyrinth capsule or extension by preform pathway. So preform pathway, I already told that oval window, round window are the preform pathway. So any infection from the middle ear, it will go to the inner ear easily. So inner ear, that bony capsule is we call as labyrinthine capsule. So any infection can spread to that area. And secondary to meningitis, mainly the suppurative labyrinthitis, it may be due to secondary meningitis. It's not due to CSOM. Okay, a patient is having meningitis due to some hematogenous spread of infection from other diseases in the body. So that from the meninges, there are connection. There are lots of blood vessel going from the inner ear to the brain. So from the meninges, from that infection may come to labyrinth and cause labyrinthitis. That is secondary to meningitis. But we are here not discussing about the secondary to meningitis. We are discussing the complication of CSOM. So symptom, if labyrinth is involved, then what will be the symptom? The symptom will be like loss of function of vestibule or cochlea. So vestibular symptom always precede the cochlear symptom. First, so if vestibule is first involved, then what will be the symptom? Vertigo, nausea, vomiting. All those symptoms will come first. Then slowly cochlea will involve, and ultimately it will lead to high frequency sensory neural hearing loss. Okay, if cochlea is involved, then obviously there will be hearing loss, and it will be sensory neural type. Then after labyrinthitis, it's labyrinthine fistula. Labyrinthine fistula means what? Fistula means communication. So there is a there will be some perforation or erosion in the semicircular canal dome. So promontory, promontory and all. So there will be some perforation in that hole. So it is communicated with semicircular canal or vestibule. It's the labyrinthine fistula. Usually it's asymptomatic, but when patient will present with symptom, it will be episodic vertigo lasting for second to minute. So anything hampering labyrinthine function, there will be vertigo. That is common sense. So if in case of labyrinthine fistula, there will be episodic type of vertigo. Okay, so for labyrinthine fistula, the most common test we do is the fistula test. You press the tragus and you see for the nystagmus. So in all patient of CSOM with vertigo, a labyrinthine fistula test is must. Okay. In any case, if came with CSOM and patient is having vertigo, you have to do one labyrinthine test, a labyrinthine fistula test, because it's easy to perform. Just press the tragus and see for the nystagmus. So you have to rule out any labyrinthine fistula for all cases. So sometimes we used to see false negative case also, like patient is having fistula, but patient when you are pressing the tragus, there is no nystagmus. Because of when? Because there is total loss of labyrinthine function. Though you are pressing the tragus and still there is fistula is there also, but still patient is not having nystagmus because his labyrinth is already dead. So it will give you a false negative fistula test. Means what? Fistula is there, but nystagmus is not there. That is false negative fistula test. And false positive fistula test is hypermobile stapes. So there sometimes this stapes may be hypermobile. So just pressing the tragus, it may lead to nystagmus. That is false positive. There is no exact fistula, but there is nystagmus. Management. So to see labyrinthine fistula, fistula test is we most commonly do, but it's not so sensitive because you already know this false positive and false negative rate is very high. So for diagnosis, the investigation of choice or test of choice is CT scan temporal bone. You have to do one CT scan temporal bone to see the fistula. Okay, treatment is surgical. So when there is fistula is small in size, like more like small than 2 millimeter, then you go through the mastoid mastoid entra. You do mastoidectomy. Canal wall up means you don't remove the posterior canal of the ESC. You just do mastoidectomy, reach the middle ear cavity, and you close the fistula with some substance. And if the fistula is bigger in size, more than 2 mm size, then you have to do mastoidectomy. Along with that, you have to remove the canal wall, means posterior wall of the medullary cavity, so that you can easily clearly this fistula will be clearly visible to you. Then you close the fistula. Then facial paralysis is one of the most dreaded complication of CSOM. There will be paralysis of the facial nerve. So mainly CSOM we are discussing. CSOM, why there is facial paralysis? Due to cholesteatoma. No? Whenever the cholesteatoma erode the fallopian canal. Fallopian canal, the facial canal only we call it as fallopian canal. When the cholesteatoma erode the facial fallopian canal, then the infection will spread to the facial nerve and it will lead to facial paralysis or direct destruction of the facial nerve. The cholesteatoma may cause facial paralysis, then granulation tissue may cause facial paralysis, and along with that, the osteitis of the I told already mastoiditis, it's osteitis. Na? The osteitis of the bone, obviously there will be destruction of the canal wall. So ultimately, the facial nerve will get exposed or destroyed. So for facial nerve paralysis also, you have to clinically examine the patient. You have to know the grading of the facial nerve palsy. There are 5 grading Houseman break, no? House Brakeman grading is there for facial nerve palsy, that you don't have to know, but just you have to examine the patient clinically. You will come to know that there is facial nerve palsy. I think you know already how to examine the facial nerve. So facial nerve palsy, you will means clinically you can diagnose. After that, you have to do HRCT temporal bone to see the cholesteatoma, to see the CSOM, not to see the facial nerve. You can see the facial canal also in HRCT temporal bone, but actual reason to do HRCT temporal bone is to see the infection or cholesteatoma. Then treatment, in case of CSOM and there is chronic facial nerve palsy, you have to do urgent facial nerve exploration or decompression. So you have to do mastoidectomy. So canal wall down mastoidectomy means the most common part to involve the facial nerve is the tympanic segment of the facial nerve. Okay, that is the part which is more oftenly get affected. So you have to do canal wall down mastoidectomy. Then you have to expose that first genu till means facial nerve from first genu to stylomastoid foramen. That is the mastoid segment actually. So you have to explore all the mastoid segment after mastoidectomy. Okay, you have to see the from first genu till stylomastoid foramen. You have to expose. You have to see the facial nerve, whether there is any destruction or whether there is any tear or broken of facial nerve. Okay, then if you see one facial nerve is broken or there is destruction of the facial nerve, then if you think that you can re-anastomose, then you have to do re-anastomosis. For facial nerve re-anastomosis, we use cable grafting. And this is also an entrance question. They may ask what procedure you follow for means nerve reconstruction. We do cable grafting. We take one part of nerve from other parts of the body, mainly gateroauricular nerve or something, and we anastomose with the facial nerve. Okay. Then coming to the intracranial complication, now time is less. I'll go just fast. That extracranial complication, intratemporal, extratemporal, I already discussed. Now intracranial complication also like similar to extracranial. Sign and symptom will be same almost in all cases. Okay, in all complications, sign and symptom will be the same. So fissures is like high grade fever will be there. So if meningitis or any involvement of the brain, obviously there will be infection is there, fever will be there, altered sensorium will be there, irritability will be there. So any infection or disease, it will lead to generalized malaise. Then in case of hydrocephalus, in case of cavernous sinus thrombosis, there will be photophobia, proptosis and all. Next deafness, then seizure, focal neurological deficit. All those symptoms will be same in all cases. Okay. And most common question is what is the most common intracranial complication? That is meningitis. I already told. So meningitis, most frequent intracranial complication. The causative agent is Haemophilus influenza, the most common cause of meningitis, and streptopneumonia. Route of infection is retrograde thrombophlebitis through the venous channel from medullary cavity. It will go to dural venous sinuses. So ultimately the dural layer, it's called meninges, na? So there will be inflammation of the meninges and bony erosion due to bony erosion. Symptom will be like same. There will be otorrhea, there will be headache, there will be vomiting, patient will be restless. Any meningeal irritation, meningitis cause restless, irritability, photophobia. Okay. So all those symptoms, it's like a broad spectrum symptom. It will be there in all cases. So you have to, in any case with CSOM, you have to ask about all the intracranial symptoms, like whether he is having vomiting, whether he is having headache, photophobia, irritable, restless, or any focal neurological deficit. You have to check everything in all cases to see any intracranial complication. Then in case of meningitis, we elicit two signs. One is Brudzinski sign, one is Karnik sign. So this exam, you have to make the patient lie down, then you have to do some test. In Brudzinski test, whenever you are, like two types are there. If you try to flex the neck, there will be flexion in the hip and knee joint. That is also called Brudzinski sign. And some books it called as whenever you are trying to flex one leg, the other leg also will get flexed. So that is also Brudzinski sign, same. And in Karnik sign, a patient will be in lying down position. There will be flexion in the hip joint. Then you are trying to extend the leg. You won't be able to extend the leg. There will be pain, tenderness, and there will be spasm. So that is Karnik sign. And then after meningitis, okay, we'll continue that about the abscesses. If the abscess collection is there outside the dural layer, it's called extradural abscess. As you can see in the first picture, the abscess collection beyond the red line, that is the dural layer, it's extradural. Then if it's inside the dura, it's called subdural abscess. And there may be accumulation of abscess inside the brain tissue, that is brain abscess. It may be in the temporal lobe or in the cerebellum. Okay, so it may be temporal lobe abscess or cerebellar abscess. So in intracranial abscess, if you see overall cause of intracranial abscess, 75% of the brain abscess is mainly due to the CSOM, that is autogenic. Okay, so to diagnose, you have to do CT scan, MRI of the brain. Then you have to start among the treatment, medical treatment, it's antibiotic. You have to start dexamethasone to decrease the cerebral edema, then mannitol to decrease the CSF pressure. Okay, and mastoid abscess you can drain, but it's not a ENT surgery. You have means neurosurgery. They used to do the mastoid abscess drainage by bar hole technique or craniotomy. And from our side, we have to remove the source of infection, that is the mastoiditis or CSM, whatever is there. We have to remove with mastoidectomy procedure, mastoid exploration. Okay, so we have to remove the cause, root, and neurosurgery people, they will remove the abscess from the brain. And among the medical treatment, you have to give antibiotic, dexamethasone, and mannitol. This mannitol, one of the entrance question, they may ask, so what do you use for intracranial abscess or to decrease the CSF pressure? There will be options like mannitol, glycerol, or many things. So mannitol will be the answer. Then one of the most common and dreaded complication of CSOM in intracranial complication is lateral sinus thrombophlebitis or sigmoid sinus thrombosis. So in lateral sinus thrombophlebitis, it may involve any sinuses like superior petrosal sinus. As you can see in the picture, number one is the superior petrosal sinus, then two is transverse sinus, third is the sigmoid sinus, and fourth is the inferior petrosal sinus. So lateral sinus, whom we call lateral sinus, that is the sigmoid sinus plus transverse sinus. Okay. So when there is inflammation of the sigmoid sinus, that is the number 3, and the transverse sinus, that is the number 2, that part. Okay, transverse sinus and sigmoid sinus, then we call it as lateral sinus thrombophlebitis or lateral sinus thrombosis. So symptom, there will be like I already told, clinical features and symptoms are similar. There will be foul smelling discharge, high picket fence fever. In sigmoid sinus thrombosis, you will get picket fence fever. you just see what do you call means picket fence fever. What is the characteristics you see in Fiverr in final exam in Fiverr? They may ask what is picket fence fever. Okay, and where do you found this picket fence fever? This you can found in sigmoid sinus thrombosis. Then other sign symptom will be there will be headache, or there will be earache, torticollis, and neck pain is due to see when there is any sigmoid sinus thrombosis. So all these sinuses ultimately drain to where? Ultimately, all the sinuses drain to internal jugular vein. So if there is any sinus thrombosis in the lateral sinus, there will be accumulation. This blood flow will be restricted from the brain to the internal jugular vein, or sometimes the thrombus itself may come to internal jugular vein and lodge there. So then it will cause neck pain and torticollis. There will be a Gressinger sign, that is tenderness and edema over the mastoid region. It's not a mastoid abscess or swelling. It's just tenderness and small slight edema over the mastoid. That is called Gressinger sign. It's due to the obstruction of the emissary vein. That emissary vein who drain from the mastoid area, that vein may get blocked due to thrombosis of the sigmoid sinus, and ultimately there will be accumulation and tenderness over the mastoid. That is called Gressinger sign. Then when the infection spread to the cavernous sinus is just above the optic chiasma. If you see the anatomy in optic chiasma, then cavernous sinus, internal carotid artery, all are interrelated. So any infection, any thrombosis in the cavernous sinus, it will lead to CSF pressure rise and will lead to proptosis, ptosis, decreased vision and all. Then in the signs, tenderness over the mastoid is not so relevant, but Gressinger sign is the pitting edema over the occipital region or mastoid region. I already told, due to emissary vein thrombosis. Then we do few tests like Krobeck test, compression of normal internal jugular vein, engorgement of the retinal vessel. It's a ophthalmoscopy finding, Krobeck sign. Whenever you press the internal jugular vein, there will be engorgement of the retinal vein due to sigmoid sinus thrombosis. If there is any, cavernous sinus thrombosis. If there is any thrombus in the cavernous sinus, if you press the internal jugular vein, the pressure will transmit directly to the retinal vein, and you can see in ophthalmoscopy. That is Krobeck sign. Then in Tobey, we do Tobey test or Quicken state test. That is, we measure the CSF pressure by doing lumbar puncture. We measure the CSF pressure. In normally when you press the internal jugular vein, there will be some pressure changes in the CSF. But in case of any thrombosis in the sigmoid sinus or internal jugular vein, if you press the internal jugular vein, that pressure won't transmit to the CSF because of the thrombus, and there won't be any pressure sense. That is called the Tobey test. I won't go in details because there is no time. So Tobey test we do. Then CT scan, MRI also we do for sigmoid sinus thrombosis. MRI, one finding that is also a entrance question. MRI finding, they may ask for sigmoid sinus thrombosis, you will get empty delta sign. So in the occipital region, there is a triangular area that will be normally black, black in color, but like if you see the MRI, then only I can explain you how it look like. You just see in net how empty delta sign will look like. Okay, you will find empty delta sign in case of sigmoid sinus thrombosis. Then treatment same as before, high dose broad spectrum antibiotic you have to start. Then surgical, incomplete mastoidectomy, sinus expose, abscess drain and clot remove. All this thing is like treatment of mastoiditis or CSOM you have to do. Mastoidectomy is for it's for to remove the cause of the thrombus, not the, you are not doing the thrombus removal. You are doing the removal of infection from the mastoid antrum. But you can break the sinus plate. When you drill the mastoid cavity, you will get one sinus plate also, that is the sigmoid sinus plate. So you can just give a nick or incision in the sigmoid sinus plate or in the sigmoid sinus layer, and you can remove the thrombus if you can palpate the thrombus. That is too tough for you, but we can remove the thrombus surgically from the sigmoid sinus. Okay. and then that is enough. Then otic hydrocephalus. So any infection, inflammation of the brain, it will lead to hydrocephalus. So it's mainly due to occurs due to raise ICP. ICP is intracranial pressure due to failure of arachnoid villi to absorb CSO. So whenever there is intracranial pressure rise, it will lead to hydrocephalus because of the edema or decreased absorption of the CSF. So hydrocephalus also sign symptom will be similar: headache, nausea, vomiting, blurring of vision, all those things. Lumbar puncture, high pressure but normal left finding means when you do lumbar puncture and you measure the pressure of CSF, you will get a high pressure. But in the CSF, if you do laboratory finding, means testing, all composition will be same. Then treatment, acetazolamide and mannitol, their main function is to reduce the intracranial pressure. Dexamethasone to reduce the cerebral edema. Then lumbar drain, you can remove the CSF by lumbar drainage. These are the treatment. So, hello. Okay.
Yes, sir.
Thanks for today. It's like a long topic. I just go very fast. I think I hope you understand little bit, but you have to read by yourself at least. Like CSOM, complication of CSOM is very important topic for your exam purpose. So you have to read it. Okay. Still, I told you as much as I can, but I don't know whether you understand anything or not. But try to read once today. Okay. And
Yes, sir.
and HOD sir told he will come, but he didn't come.
Yes, sir.
Though I think he will call you. Okay.
Okay.
Okay. Bye bye.
Okay, bye bye.
Yes, sir.